Hello everyone, this course is a part of the project funded by the European Union and Russian Federation. The name of the project is Promotion of Breast and Colorectal Cancer Prevention Measures in Cross-Border Territories. The name of this course is Fight with Colorectal Cancer. My name is Denis Shimchikas and I work at Day Surgery Center of Republican Klaipėda Hospital and also in Klaipėda University. This is an episode number 5, and I would like to continue my talk about the performance measures in colonoscopy in our everyday practice. As a frame for this talk, I would like to use beautiful guideline published by European Society of Gastrointestinal Endoscopy in year 2017. The guideline authors pericolonoscopic period divide into 7 domains, where each domain has one key performance measure and may have few minor performance measures. In previous episodes, I was talking about the patient's consultation and looking for indications for colonoscopy, about how patient should prepare the bowel for colonoscopy. Then I was talking about the sedation, gas insufflation into the colon, insertion of the endoscope, and cecal intubation. In this episode, I would like to talk about the identification of pathology domain and start with the extubation, or in other words, withdrawal of the colonoscope. Close examination of the colonic mucosa is best done during extubation. Extubation key points are: inflate enough to get clear views, aspirate once a segment has been examined, and take care of examine behind flexures and folds. Care should be taken to examine very carefully because it is so easy to miss such flat lesions. Another example: at first look, it looks like remnant of bowel content, but after we wash the mucus away, it appears to be flat lesion. I touch with the tip of the instrument, suck a little bit air out, and the polyp shows its borders. After this polyp was removed, the pathology assessment concluded it was sessile serrated adenoma. Should we perform cecal and rectal retroflexion during withdrawal? I think cecal retroflexion is not necessary if you see clearly behind the ileocecal valve. Besides, there are few case reports that cecal retroflexion gives complications. What about rectal retroflexion? I think if there are no contraindications to perform this action, it should be performed in every colonoscopy because it is easy to miss the neoplasia of distal rectum and anal canal if we do not perform retroflexion. These are the examples of squamous-cellular carcinoma. In the second case, while taking biopsy from the lesion, to be honest, I did not expect it to be squamous-cellular carcinoma. Let's move to the third key performance measure, which is adenoma detection rate. Adenoma detection rate, ADR, is a percentage of colonoscopies with at least one adenoma identified. Adenoma detection rate reflects adequate inspection of the bowel mucosa. Adenoma detection rate is associated with interval colorectal cancer and colorectal cancer death, with improvement in the adenoma detection rate lowering the risk of CRC and CRC death. Minimum standard recommended by guideline authors is more than 25% of all the colonoscopies. If the minimum standard is not met by an individual endoscopist, appropriate feedback followed by a competence assessment should be given. Detection rate of serrated polyps has been shown to strongly correlate with the ADR. ADR actually has the limitation of not measuring the total number of adenomas detected. A potentially more accurate measure, namely number of polyp adenomas per colonoscopy, a potentially more accurate measure, namely number of adenomas per colonoscopy, has been proposed, but this was proven not to be superior to ADR in a recent study. What do we do to increase our ADR? We do everything to have perfect bowel preparation, to intubate cecum, to inspect carefully. Plus, we use mechanical attachments to unfold the folds of the colon unless it is necessary to intubate ileum. Most commonly, we use endocuff vision. Also, it is possible to use endo-ring or a special colonoscope with balloon at the end of colonoscope. This is an example of endocuff vision. We put it on the tip of the colonoscope. During the withdrawal, the arms of endocuff vision unfold the folds of the colon, and thus it helped us to find this early cancer of 1 centimeter size. And as I mentioned before, there are few more mechanical devices which can help us to detect more adenomas, such as endo-ring or specially made colonoscope with a balloon on the end of the colonoscope. The pressure in this balloon is controlled by the endoscopist and also by the special device attached to the endoscope, which prevents the colon from the traumatization. What else can help us to increase our adenoma detection rate? Possibilities are beautifully described in ESGE guideline about advanced imaging for detection and differentiation of colorectal neoplasia. This guideline was updated in 2019. Of course, I must mention artificial intelligence devices, which detect artifacts in colon much faster than the eye of the endoscopist. In this case, artificial intelligence device showing blue square warns the endoscopist about the possible lesion, and it appears to be adenoma of 4 mm size. I would like to share our results in finding malignant and pre-malignant lesions. During first 300 colonoscopies done in our day surgery center, we found 12 cancers, which is 4% of all the pathology. We found 166 benign tumors, which is 55% of all the cases. And to sum up these results together, I may conclude where we found totally 178 patients from 300 patients who had pre-malignant or malignant lesions. It is 59% of all our performed colonoscopies. One cancer was lymphoma, one decode, which usually is considered pre-malignant, was lipoma. But I must mention the fact that sessile serrated adenomas, which actually are precancerous lesions, they are under the K code, which is considered not to be precancerous lesion. So finding so many adenomas and cancers, I think we do a really good job. This is the picture of lymphoma that I mentioned, and this is the picture of lipoma near ileocecal valve. Further, I would like to talk a little bit about the minor performance measures of identification of pathology domain, that is withdrawal time. And withdrawal time is the time spent on withdrawal of the endoscope from cecum to anal canal and inspection of the entire bowel mucosa at negative, that means no biopsy or therapy, screening or diagnostic colonoscopy. Studies show that a mean withdrawal time of 6 minutes or longer was associated with higher adenoma detection rates and lower interval cancer rates as compared to shorter withdrawal times. Minimum standard recommended by ESG group is mean 6 minutes. Target standard is mean 10 minutes. Time can be measured by different methods. Stopwatch operated by a nurse, timestamp on photo documentation of the cecum and rectum, length of video recording, or external device. Withdrawal times should be measured only when the ADR is insufficient. However, withdrawal technique is more important than the withdrawal time. And I would like to remind once again that withdrawal key points are: inflate enough to get clear views, aspirate once a segment has been examined, take care to examine behind flexures and folds, and actually both are not good. Withdrawal time in 5 seconds, and the endoscopist's excuse was, "I've checked everything while inserting the colonoscope." Also, it is not good when the withdrawal time is 25 minutes with lots of time spent watching at one point. Next minor performance measure is polyp detection rate. Polyp detection rate is a percentage of colonoscopies in patients aged 50 years or older in which at least one polyp was identified. It has been shown that polyp detection rate reflects adequate inspection of bowel mucosa. Also, polyp detection rate correlates with adenoma detection rate, and polypectomy rate is weakly associated with interval colorectal cancer risk. Minimum standard is 40% of all the colonoscopies, and it is important to mention that polyp detection rate is an approximation of adenoma detection rate and should only be used when there is limited access to histopathology. I would like to share our experience. What do we do when we find many polyps? Actually, what we do, we describe all of them. Our nurse assistant documents what I say, and she makes the list for me. That it would not be necessary for me to watch the video and describe each polyp carefully. And we use codes. I, for example, means ileum. It means I intubated ileum. C means cecum. 3 mm means there is 3 mm size polyp in cecum. 1S means sessile. Ad means it looks like adenoma. B1 means biopsy number 1. -2 means 2 pieces. And I remember that with those 2 pieces I removed 3 mm size polyp completely with biopsy forceps. I means ileum, C cecum, A ascendens colon, hepatic flexure, transverse colon, lianalis, that means splenic flexure, descending colon, sigmoid colon, and rectum. One more example, if I say A 7 mm 1 SP add B2 minus 1 cold loop, it means I found a polyp in ascending colon, which is 7 mm size, subpediculated, looks like adenoma. I took biopsy number 2, 1 piece, and I removed it with cold loop technique. This is the end of the episode number 5, where I talked about the identification of the pathology. And in next episode, I would like to talk about the management of the pathology that we found. Thank you very much for your attention.